So thank you everybody for joining us today for our impact of exercise on prostate cancer management with Professor Galvão. Professor Galvão is a Director of Exercise Medicine at Edith Cowan University in Western Australia. The Professor in the School of Medical and Health Sciences at Edith Cowan as well. His research programs focus on applications of exercise as medicine for the prevention and management of prostate cancer treatment side effects and survival. Now, I've had the privilege of speaking alongside Professor Galvão, and there's not much he doesn't know about exercise and prostate cancer. So I'll hand over to you for today's presentation, Daniel, and then we'll finish the day with a Q&A session at the end. So any questions that you have as the presentation proceeds, just pop them into the Q&A box at the bottom of the screen, and we'll endeavour to get to those during the presentation. Thank you very much. Over to you, Daniel.
Great. Thank you, Chris. Thank you very much for the opportunity to be presenting today. It's always a pleasure to work with PCFA, and thanks for everyone joining in. It's great, and we're going through some difficult times. Some of you are in lockdown, not available to leave your houses, and so it's great to be able to share some of this research data and work in exercise in prostate cancer with you. So we have a lot to cover today, and and as Chris said, we'll be able to have a bit of a chat towards the end, and I'll try to do my best to answer your questions. So the content for the talk today is around exercise medicine for prostate cancer. Our team has been working in this space for a number of years, doing some very interesting work and important work that has national and also international impact. We'll discuss some of the research work in the area of exercise prior to treatment. This is more specifically for patients that are about to have radical prostatectomy. Is there a role for exercise in that setting? A lot of the work has been done in exercise for men with prostate cancer during treatment. These are patients that are receiving androgen deprivation therapy, for example, or radiation therapy. So we're going to be discussing a lot of these studies. There's a lot of data out there supporting the importance of exercise during treatment. There's also work done post-treatment when you finish your treatment. What's the benefit of being physically active in relation to your health and also to prostate cancer? Patients with advanced disease prostate cancer, this is a group of patients that were normally excluded from exercise studies or an exercise community program. So there's some important data that have been accumulating in this space. So we'll talk about this as well. Then we're moving to exercise and prostate cancer outcomes. We now know, and we're showing some data, that exercise is important to improve quality of life and a number of other aspects. But what about survival? So there's also interesting work being conducted in this space, as well as some of the potential biological mechanisms that are supporting the specific role of exercise in potentially improving survival. And also, and most important, what can you do now? What clinicians can actually do now? Allied health professionals, urologists, medical oncologists, GP, and patients. There's a lot of tools out there that can be used straight away in helping them with prostate cancer, going through this disease, and improve a number of outcomes with exercise medicine. So before we get into some of the data in relation to research specifically to prostate cancer, I think it's important just to explain. Some of you might not have the understanding in these two different aspects of exercise and the modalities of exercise. So there's physical activity, which is really just moving and doing some sort of any incidental activity. And there's exercise prescription, which is more it has a purpose to improve certain outcomes, specifically physical and functional outcomes. And within this, there's two main exercise modalities. You'll be very familiar with those. One is aerobic training, which is more activities like walking, swimming, cycling. They often are longer duration, involving large muscle groups. They can be done continuously or intermittent, about 20 minutes or higher, greater volume of exercise and quantity of exercise. It can be done with less time as well, but ideally building up to 20 minutes or longer. The intensity with aerobic exercise is normally monitored by heart rate or perceived exertion, or the exertion that the patient has, how hard he thinks the activity is. So these are some of the examples. Now, resistance training, also known as strength training, you'll be familiar with strength training. It's really lifting weights and using right technique. And It can be done with machines, like elastics and dumbbells. Often you're working against the resistance, and the aim here is really to improve muscle hypertrophy and improve the musculoskeletal system, as opposed to cardiovascular training is more a cardiovascular side of outcome. So there's differences in relation to these two modalities that are important. So as we go and understand the different studies that were done in this area, it's important to understand these different exercise modalities. So cancer patients, not just prostate cancer specifically, or in cancer survivors, I mean, we know it's well established to experience a number of aspects of physical and psychological effects. And then this is within the area of cancer survivorship. Following treatment, what to do, how do we improve quality of life? And this is to do a lot with the actual treatments. They're very effective. People are living much longer, specifically in prostate cancer, a lot longer, especially if you have local disease. It's almost like a chronic disease, right? You know, you go for 20, 30 years, survival is actually exceptional high. However, the treatments, they will lead to some toxicities and side effects. In the case of ADT or hormone therapy, we'll talk a lot about ADT because this has been actually studied quite extensively from an exercise science perspective. This is sort of a framework that we've presented earlier back a number of years ago, that ADT in a way accelerates the aging process because you withdraw testosterone. It controls prostate cancer, is very effective to control the disease, but by withdrawing testosterone, there's a decline in musculoskeletal health and physical reserve capacity. So there's an acceleration of this process, and this potential role of exercise, particularly in this setting of resistance training, to offset a lot of these toxicities. So ADT, again, hormone therapy, you might know as hormone therapy or androgen suppression therapy, leads to a number of issues around musculoskeletal health, cardiovascular risk factors, and bone issues in terms of losing bone mass, metabolic complications, fatigue, poor balance, decline in physical capacity. So it is a combination of side effects, which is problematic. And exercise medicine can actually offset a lot of these issues. Interesting, when we started working in this area and went back to the literature, this is now published 16, 17 years ago, there were only 20 studies in the area of exercise and cancer. The large majority of these studies were done in breast cancer. There was only one study in prostate cancer, and this sort of caught our attention quite substantially. And we thought about, you know, we need to understand if exercise can be used in the setting of prostate cancer. So at the time, the preliminary evidence was for a positive outcome in terms of physiological and psychological benefits. This is mostly for women receiving treatment for breast cancer. So since then, our team here in Western Australia, we're really focused in prostate cancer and how can we actually apply it and then do research, then we can generate evidence and knowledge that we can improve patient outcomes, specifically in prostate cancer. And I will show you a couple of these studies that we've conducted over the past 15 years. So the first one we spoke earlier, you know, throughout the disease trajectory, this is how we're going to plan this presentation. Exercise prior treatment. There's a couple of studies, one from our group. The whole idea here, and this is a published paper by Fav Hussein that works with our team. The idea here, it's prehabilitation. Instead of waiting for patients to be rehabilitated later following surgery, can we actually improve their reserve capacity so they might do better right following surgery, do it to bed rest and time without being able to do any activity. So this is the hypothesis for this type of work is, so patients that will have a major surgical procedure and patients will potentially improve that reserve capacity before, in this case, radical prostatectomy. So following surgery, they have a little bit more room in terms of the physical capacity and physical function compared to others that didn't have that reserve capacity. And they tend to bounce back better following surgery. So the design for this study was that patients were exercising. This is a combination of aerobic and resistance training twice a week. This is a supervised exercise program by an accredited exercise physiologist. This is about 6 weeks before their radical prostatectomy. And this is the outcome. So basically, this is baseline data. This is across different muscle strength measurements. Before surgery, they tend to improve. So this is basically leading to surgery. They improve that reserve capacity. Following surgery, they have an expected decline. This decline would likely to be greater without this prehabilitation aspect of with this type of work. And this is across a number of different measures of muscle strength. So patients tend to go up and then they build that reserve capacity and they follow after surgery, but they don't follow as much if they don't have that prehabilitation aspect and the building up of the reserve capacity. So interesting opportunity for those patients that are about to have radical prostatectomy. Of course, there's also the cohort on active surveillance, and we won't be talking today because there's just no time. But active surveillance is also a strategy that patients are being monitored, but they don't have an active treatment as yet. But they could potentially be preparing if there's a case for radical prostatectomy or radiation. They can undergo an exercise program and get that prehabilitation aspect of it. So exercise during treatment, and we spend a lot of time here because there's a lot of work done in this area. And we spoke about ADT and the potential side effects of ADT. This is data from a very large national study, specifically patients in Western Australia publishing this work. We know the PSA drops substantially with ADT, so that's great. It's amazing, it's fantastic. It controls the cancer. Testosterone drops substantially. So cancer is being controlled substantially. The problems that we spoke earlier is some of the side effects associated with ADT. These are the changes in components of body composition like lean mass, appendicular muscle mass, which is the muscles within the limbs and the arms, fat mass and trunk mass. So fat mass and trunk mass going up and muscle mass going down, which is problematic. And if you see it over time, this is 9 months of therapy. So there's drastic changes that are happening very, very quickly, very, very quickly. You're thinking that men with prostate cancer, they will be in their 60s or older. There will be some sort of muscle loss already associated with aging and also some fat gain. And this is in a way exacerbated with this type of therapy. Interesting, when men, they do stop ADT, they don't tend to recover by itself. So again, there's a huge opportunity for exercise to improve these outcomes. So the problem is that not just changes are happening in body composition per se, but these are actually having some important implications to physical function, activities of daily living, and functional measurements. I mean, this is an example of a cross-sectional study that we examined patients that were on ADT compared to controls. These patients on ADT, they tend to be weaker, more fatigue, and a less ability to perform activity of daily livings. So it is a combination of issues, not just the actual changes in body composition, but the implication of these changes. And interesting from a bone health perspective, and you might have heard some of these consequences of ADT. A lot of these patients might lose their bone because of the withdrawal of testosterone. Over time, this can be a problem. This is an early Italian study showing that over 10 years, a lot of these patients will develop either osteoporosis or osteopenia, which it happens just before osteoporosis. It's just the initial loss of bone mass associated with aging that it's in a way exacerbated with ADT. So can exercise help? Now, so we established that exercise has a potential role here in the setting of prostatectomy, more from a functional perspective. There's still data pending on urinary and sexual function. The data is sort of still pending. There's some groups in Canada doing this work. We're looking forward to see that data. Now, we're talking about patients that are receiving therapy, specifically androgen deprivation therapy that is often used with the radiation therapy. And there are side effects. So this is an example of an exercise medicine study, an early study that we use at resistance training. That's the modality that we spoke about, leading to improvement in hypertrophy and improving the musculoskeletal system. So this was one of the first studies. This is published back now in 2006, showing that these patients on ADT with prostate cancer, they can improve their muscle strength, even though they don't have testosterone, that they've been using that medication. And this translates in improvements in physical function. So these are important outcomes for patients with prostate cancer because you're likely to improve quality of life and be able to do things that you normally were able to do it before ADT. So we extended this work, and this is a more sophisticated design. So it's a randomized controlled trial. This was published in the Journal of Clinical Oncology a few years ago. That we had a 12 weeks intervention that where we combined aerobic, the cardiovascular type of exercise, with resistance training. All these patients were on ADT. Some of these patients were on radiation therapy, mostly patients with local disease, local prostate cancer. So this was a supervised exercise program. intensity, moderate to high intensity. And this is what we find. These are the differences between groups at 12 weeks for the group that did exercise compared to the controls that did not do the exercise, only received ADT. So these are the differences between group for whole lean body mass and a particular skeletal muscle. So there's a benefit of close to a kilogram, about 800 grams of muscle that is being preserved or increased for the group that is actually undertaking the exercise program. These are quite important and clinical important because patients are losing their muscle mass, about 2.5 kilos within 6 months, 9 months. So here, you're not just preserving, but you're having increases in muscle mass with the right exercise prescription. So you're really offsetting that toxicity related to muscle loss. And also, patients are also improving their quality of life, which is important. These are instruments that measures their self-well-being, for example, here in general health, and vitality, which is the opposite of fatigue. Patients are improving at a clinical relevant scale. So they're improving meaningful changes in their quality of life with an exercise program. So we spoke about 2 different studies. One was specifically in resistance training, an early study, and then a follow-up study that was the combination of resistance and aerobic training. This was a very large study now that I'm presenting now. This was a large, probably the largest study ever done internationally in exercising men with prostate cancer that has been completed. 163 men. We had sites in Queensland and in Western Australia. This was funded by the NHMRC. So all these patients, again, they were on ADT. A large proportion of these patients had radiation therapy at some stage of this year. And again, most patients here had localized disease, no bone metastasis. And we'll talk about bone metastasis a little bit later. So this was a study that we had 3 arms, 3 groups. One group doing an osteogenic type of exercise, which includes impact loading, in addition to resistance training. The whole idea was just to preserve bone. And we know from other literature, postmenopausal women, that this type of work can actually preserve and enhance bone mass. This wasn't done in patients on ADT as yet. We also had a more traditional group, this gray group here, that did the resistance training and aerobic training. This is over 12 months. This group had exercise supervisor for 6 months, and then they had a follow-up at home with a home program. And we also had a delay group that started the exercise at 6 months. So they were delayed for 6 months to control for certain measures that we had in the other groups. And this is some of the data. We'll talk about some of the self-reported data and some of the physiological data. This is quite interesting. This is the bone data. As expected, the delayed and aerobic exercise, they are reducing the bone mass over time, about 12 months, 6 months. There's a reduction of about 2%, 2.5% of bone mass. Interesting and surprising to us and to I guess, the scientific community, aerobic and resistance exercise alone were not able to contain and reduce this loss of bone mass, which is problematic. And as we we thought, and this was the hypothesis for this study, that resistance training and the jumping activity, the type of more osteogenic type of exercise, was able to actually preserve it, so minimize the loss of bone. These patients were not on bisphosphonate and taking only medication for bone. And we actually thought initially that this group would actually do okay, but it seems to be very severe, this withdrawal of testosterone in relation to the loss of bone mass. So exercise can only do so much, but it can minimize some of the loss if it's prescribed with the right mode, in this case, some osteogenic type of intervention. Now we're looking at some other aspects of this study. This is just another publication looking at outcomes of cardiovascular disease. As expected, the group that does aerobic training in combination with resistance training, they do better in terms of improving their VO2, which is cardiovascular fitness, which is an important protective marker against cardiovascular disease, as opposed to controls that they tend to decline. And again, it's kind of as expected. If you're not exercising, you're likely to decline your cardiovascular function. This is another follow-up important outcome for this study, which is fatigue. Fatigue is a major issue. I mean, can be during radiation or during androgen deprivation therapy. It's well established. What's interesting from this data is that pretty much all exercise groups, all the men, they improve the outcomes and they reduce their fatigue throughout the 12 months, and they improve their vitality. And what's interesting is that when we divided the groups in quartiles, the group that had higher levels of fatigue at baseline, it was the group that had a better response. And against the same for vitality, group that had the lower levels of vitality had the higher response. So the big message here for this particular study in relation to fatigue is that any exercise modality works for these patients. They're experiencing fatigue and vitality, and the more symptoms, the better the response. That's interesting because symptoms, fatigue, it can be viewed as a barrier to initiate an exercise program. So in fact, if you do have fatigue and if the levels are higher, you're likely to have a better response with exercise. And just to follow up, again, this is also data, just a recent publication from this large NHMRC study that we're looking at different exercise modalities. Here we're looking at distress, which is a major issue for men with prostate cancer undergoing therapy, making decisions about treatment and so on. So we're looking at levels of anxiety and distress in terms of levels of symptoms of depression. So we found that all these exercise modalities were effective in improving these symptoms of anxiety and depression, which is a very important outcome for men with prostate cancer. These were supervised exercise though, so we think supervised exercise is probably appropriate in this setting. Similar to the fatigue data, this is the data was sort of split in tertiles. Patients that had more anxiety at baseline, beginning of the study, they had a better response, better reduction in symptoms of anxiety. And it's similar for depression. Patients that had more depression at baseline, they had a better response, the tertile. They had a better response in relation to reducing symptoms. These patients were not necessarily clinically depressed, and we didn't screen for that at baseline. These are symptoms that can be picked up due to validated scientific questionnaires. Similar to global severity index and also somatization. So sort of distress measures. Patients that had more issues with distress, they had a better response following 12 months of exercise. And during treatment, and I'll present this important review and meta-analysis that was just recently published by one of our PhD students, Oliver Schumacher, with outstanding work in the setting of exercise and radiation therapy and perfusion, and we might talk about this a little bit later. But specifically for this review, Oliver looked at the studies that were done during radiation therapy. Most of these studies on ADT. This is a review of the pooled studies that patients were undergoing radiation therapy while exercising. Again, mostly resistance and aerobic training. So this is data from 7 publications from 6 RCTs or clinical trials, close to 400 participants at different stages of the prostate cancer Gleason score from 6 to 10. So interesting that exercise, the data here showing that exercise during radiation therapy improves physical function and also mitigates some urinary toxicity. So it improves aspects of urinary dysfunction that it's likely to be associated with radiation therapy. So this data here, it's very busy, but I'll just show you the main results, which is this forest plot graph that shows the pool data for cardiorespiratory fitness here in 1, 2, 3, 4, 5, 6 studies, show there is a protective effect. Exercise during radiation can improve cardiorespiratory fitness, which is probably suspected, but this is novel data. Exercise might help with urinary toxicity during radiation therapy. So it's really interesting clinical data that, we're very, very pleased to share that this work was just published a week ago and it's now available, open access in PubMed. So we'll talk about exercise post-treatment as the next section of the presentation. So there's less studies in this space, and I will present one study from our group. This is the RADAR study. This was a clinical trial funded by Prostate Cancer Foundation of Australia. We had sites in Australia and New Zealand. We had 14 exercise clinics. These were patients that had completed radiation and androgen deprivation therapy. So it was a slightly older group of patients than the previous studies. They were in their 80s plus. So the design here, this was a randomization in usual care. These patients received an educational material of exercise or printed material about physical activity and exercise, no supervision per se. Or they were randomized to a group that they received an exercise supervision across these 14 clinics in Australia and New Zealand. And they undertook moderate to high intensity resistance and aerobic training for 6 months. And then they will follow up with an exercise program in a home program for the following 6 months, totaling 12 months of the intervention. So again, for patients that had completed their therapy, we see that exercise here in the blue This is their performance for 400-meter walk, their ability to walk faster during 400 meters. They improved with exercise as expected, and then they maintained that with a home program. And this is sort of relevant data now with COVID-19, patients having to stay at home. You can sort of maintain your adaptations from exercise if you continue with the home program. That's what the study is actually showing. As compared to physical activity printed material programs, there's very little change here for patients, just giving them something, go do it at home. So I guess our lessons from this is that some sort of supervision is important, especially initially, in initial months, to get patients going. So this is similar for chair rise. It's a functional measurement. There's an improvement in time, and they sort of preserve with a home program. Very little change happening for the print material, educational material. And muscle strength, you can sort of see a similar pattern here. Patients are moving up, they're improving their muscle strength, and they preserve with a home program. Very little happening, if not a decline for the ones that are only receiving printed material. Similar for lower body muscle strength. So they're going up, they're preserving, very little change for those that are not really receiving a supervision or supervised exercise program. Self-reported outcome, as in previous studies, is also a very important outcome for patients. And we see these patients are improving. These are the differences between the two groups at 6 and 12 months. Physical function is being improved by the supervisor group. Interesting, social functioning, there's an interaction here, and I'm improving this specific subscale for patients who are receiving the supervised exercise component. When they move to a home program, that change disappears. And also improvements in mental health composite score within the initial 6 months of training. This is probably telling us something to do with that group interaction is also important for men with prostate cancer. And it's kind of well suggested in the literature that if you're working in groups in an exercise program, it's probably beneficial. And we can talk more about this. I think there might be a question related to this later. So, and also we're going to move them. So we spoke about prior treatment, during treatment, post-treatment, a couple of examples. What about patients with advanced disease? That none of these patients were actually included in these previous studies. So this led to a question, clinicians bringing us the questions and said, well, what about patients with bone metastasis? Often they are at an advanced stage. They might be receiving additional therapies like chemotherapies. Today, there's more therapies for these patients that have metastatic disease. Can exercise be undertaken in a safe way? And we thought about testing this, and this work was published just 2-3 years ago, where we kind of developed with some radiation oncologists and some imaging clinicians a modular exercise program that will take into consideration the sites of the lesions. So patients will have bone lesions in different locations. The idea of this program was to undertake a program that you wouldn't be loading the specific sites with metastasis. So as you can see, for the inclusion criteria, a lot of these patients had extensive disease. Large majority had pelvis, femur, spine disease, lumbar spine, and even humerus disease. So the program was very individualized. It was mainly based on resistance training, aerobic training, but very individualized by their disease location. So a large majority was on ADT. Some had radiation therapy. Even some patients at the time had chemotherapy. So had 57 patients that took part of this study. This work was also funded by Prostate Cancer Foundation of Australia at the time. So it was published in 2018. So they went for 12 weeks. So the whole idea here was to test feasibility. Can these patients safely undertake a program? And yes, the high attendance was high. We were concerned about skeletal fractures and adverse events, which didn't occur, which was a positive outcome for this study. Intensity of this exercise program was still pretty decent, 12 out of 6 to 20 in a Borg scale. This is a perceived exertion scale. Tolerance to the program was pretty high. Patients were able to tolerate quite well. Bone pain was low, which is, again, it's a concern, although we did exclude patients for this study that had substantial and severe bone pain based on the clinical judgment of their treating physician. So most of the patients did have extensive bone pain starting, but again, bone pain was not exacerbated for those that had metastatic disease. And in terms of efficacy, patients were able to improve their physical functioning. This was the primary outcome. So improving their ability to do activities of daily living. This is an important outcome for patients. And also an objective measurement of muscle strength, which was the leg extension also improved substantially for the patients that did the exercise program. So in summary, patients with bone metastasis, they can also exercise. Supervision is probably important in this setting, and we would recommend this type of modular exercise prescription that you're not directly loading the skeletal lesions that have metastasis. What about the survival data? A lot of people are now asking about survival data. Okay, there's a lot of strong evidence about improving outcomes, reducing toxicities. Survival data, and the survival data and the potential biological mechanisms associated with survival data. When you do show a benefit in terms of survival, trying to explain biologically how this might be actually taking place. So the survival data comes from a lot of these epidemiological studies. This is some great work from Christine Friedenrich from Canada, and she pulled all these epidemiological studies together. This is a forest plot across different cancers: breast, colorectal, prostate. There were about 4 studies at the time. I think there's about 6 or 7 now. Everything that you see going to the left side, your left side, is a protective effect. So these studies, they have a consistent data showing a protective effect of exercise in relation to survival or reducing mortality. Patients that are more active following a cancer diagnosis, this is specifically breast, colorectal, and prostate, they have a protective effect, a reduced risk. And this is about 37% reduction in risk of cancer-specific mortality, which is quite substantial. But these are associations, not cause and effect. So clinical trials are important. Phase 3, definitely clinical trials are important to confirm some of these findings. This is really giving us a sign that something's probably happening there, with patients more physically active, having greater survival. This is with cancer. So, and this, which it is really the basis for GAP4, funded by Movember. This is an international trial that has sites in Australia, in Europe, in North America. And yeah, we're running, there's sites in Western Australia, there's sites in Victoria, and I think New South Wales for this study. These are patients that have advanced disease. And the whole idea, the whole principle of this study is to try to determine that if exercise improves survival in men with advanced prostate cancer. The rationale and the hypothesis behind it is actually pretty strong. So this is an ongoing study, and which is recruiting patients at the moment here nationally and also internationally. We're thinking in a few years we're going to have interesting data coming out from this trial. Potential mechanisms associated with exercise and improved survival that have been proposed is that exercise might improve the tolerance of therapy. This is not just specifically to prostate, but across other cancers, by preserving lean mass or improving lean mass, improving function, improving immune cells, reducing side effects and toxicities of treatment. Patients might have a better tolerance. And it might also lead to improved efficiency or efficacy of the actual treatment. This is through angiogenesis or intratumoral vascularization, so bringing the vascularization within the tumor, facilitating perfusion of the blood within the tumor. This is, again, it can be specific to prostate cancer. Reducing hypoxia, which is the lack of oxygen within the tumor. Hypoxia leads to more aggressive tumors. This is kind of well established within the literature. And also facilitating the infiltration of immune cells. This work has been proposed and it's kind of well established in preclinical models, in some models, that exercise might facilitate this movement of some immune cells to the actual tumor. So these are some of potential ideas and research areas that are actually being conducted at the moment, including our lab. And here we propose some potential areas of exercise might be influenced in a positive way, tumor biology, again, through vascularization, to immune function, endocrine system, and also the role of myokines that we will talk very soon. These are cytokines being released by the contracting muscle while you're exercising. And talking about myokines, this is an outstanding review from one of our PhD students, Jim Su, that's doing work specifically in this area. This was just recently published in Nature Reviews Urology, basically suggesting the myokines, these are very small proteins. They're cytokines, but they're myokines because they're called myokines as being released by the contracting muscle while you're exercising. And some of these myokines, in the case of IL-6, for example, they might have a role in enhancing the immune system and facilitating this infiltration of immune cells to the actual tumor. This is an absolute huge area for research, and we're very active in this space, in particular with Jim Su leading this work here at Edith Cowan. So yeah, so it's almost like we're having our own pharmacy, and depending on the exercise modes and modalities, you're sort of releasing these myokines within the different systems and offsetting and regressing tumor progression and proliferation. So it's exciting to be working in this space. There's a lot more to come in this area. And what can we do now? I mean, there's the data in toxicities and side effects, quality of life, the epidemiological data in potential survival, showing all these associations. There's also a lot of work looking at biological mechanisms, which is really important, and to understand what's actually happening and taking place, so we can better dictate exercise prescription. But what can we do now as allied health professionals and physicians, urologists working in this space? So I will discuss very briefly some updated exercise guidelines specifically to prostate cancer. So this is a document that was published just a year and a half ago by the American Cancer Society. This was a major sort of a roundtable with 17 partner organizations, including the American College of Sports Medicine, American Cancer Society, Exercise and Sports Science in Australia, which was published this is a major clinical journal in oncology, naming exercise as medicine in the setting of oncology. And how can we engage clinicians to help patients move more through cancer? This is through a number of cancers, including prostate cancer. So we won't go in a lot of details of these different pathways. This is to facilitate clinical connection and clinical referrals to exercise programs for patients with cancer. But the sort of data that's summarized from this work is that exercise lowers the risk primary prevention to a number of cancers, not prostate cancer per se, even though there is some interesting data in aggressive prostate cancer, but the data is not clear for primary prevention, okay? But for those that have prostate cancer, in addition to breast and colon cancer, as we've shown in that epidemiological data graph, exercise has a protective effect for those that are more active than less active. We also show a lot of data. This is across many cancers, but we show a lot of data, strong data in prostate cancer. Exercise helps with fatigue, anxiety, depression, physical function, quality of life. These are very meaningful outcomes for patients. And there's a recommendation for future research in how we integrate exercise in cancer care. We have a lot of good things happening already in Australia, and we'll talk about those, but how can we enhance that? And not just in Australia, but also internationally. An important area of how exercise influences tumor biology, that work in mechanisms is also quite important, so we can better understand the physiology and biology of exercise in relation to prostate cancer. So Exercise and Sports Science in Australia, this is the peak of exercise science professional organization in Australia. ESSA put an updated guidelines in exercise recommendations for cancer patients. There's a lot of details here. This is more directed to allied health professionals. But the main thing here is that exercise should be guided and individualized for the patient needs, priorities, what are the specific needs. One size cannot fit all. So exercise has to be prescribed and individualized to the actual requirements of the patient. There's a range of steps that the allied health professional can take when working with the patient. So understanding comorbidities, for example, determining priorities, considering economical access. I'm in rural areas, how can I have access to exercise as opposed to major metropolitan cities? And then exercise can be prescribed accordingly, right? And also reassess from time to time and giving feedback to the patient. So this is an interesting framework that was recently proposed, and it's being used quite substantially by exercise physiologists. And the current recommendations from ESSA, this is just initial recommendations that, again, this is just published in a way in this recent paper in Nature Reviews. It's really talking about the opportunities for aerobic exercise and resistance exercise. This will be the priority of the actual prescription on the patient. It will depend on the individual needs of the patient. But roughly, aerobic exercise, as we spoke, can be continuous or interval, potentially greater than 20 minutes if it's possible. If it's not possible, it's okay to build up to 20 minutes. Ideally daily, and avoid consecutive days without aerobic exercise. These are the walking, swimming, cycling type of exercises. Resistance training at moderate to high intensity, including major muscle groups. This is the strength training, at least twice a week. It can be done more than twice a week if you're alternating muscle groups. And again, an accredited exercise physiologist should be able to facilitate and prescribe that program. There's also aspect of modification of exercise. It's important to modify from time to time. Periodization, when you can change the levels of intensity and volume, quantity and intensity of the work, and auto-regulation, how the patients actually feel. Depending on their feelings, they might gonna have bad days and good days. This can be adjusted throughout. Specifically for prostate cancer, this is actually quite interesting. This is a data from ESSA. So these are specific issues for prostate cancer: fatigue, recommendations. Again, we spoke about, provided data that any exercise prescription works for fatigue. And this might be different for sarcopenia. You know, the emphasis on resistance training might be more important in this case. Patients that are overweight or obese and have high fat mass. These patients might have a need to preserve muscle mass, but also to expend more energy and also to reduce the caloric intake so they can better have outcomes in relation to the body composition. So all these considerations are well detailed and presented in this document. And also 3 more aspects in relation to cardiovascular disease. It can be common in men with prostate cancer. So I think we think supervision is important for patients that have had a major cardiovascular event, at least initially. Patients that are losing bone mass and have osteoporosis. We spoke about high impact loading, osteogenic type of exercise. These are also important exercise for this group of patients. And bone metastasis. Patients that have metastasis, they can exercise, but they should be avoiding the opposite, loading of the specific areas that have a metastatic site. So a number of considerations in relation to these aspects that are very highly related to prostate cancer. So some final considerations: there's emerging evidence that exercise has an important role in pre-treatment. This is in addition to pelvic floor activity, which is standard of care. It's used extensively. We're talking about resistance training, aerobic training. They might improve functional outcomes, and patients might do better post-treatment. There's extensive data here and evidence and the role of exercise during treatment, specific for radiation androgen deprivation therapy. Some aspects are related to specificity with the prescription, but some aspects of like things like fatigue, any exercise prescription will be beneficial, as well as psychological distress. So depending on the outcome, the exercise prescription should be prescribed accordingly. There's evidence, initial evidence that exercise it's okay for patients with advanced disease. Clinical data is sort of lacking in terms of the efficacy on cancer outcomes, but trials like GAP4 are underway and they will respond to some of these questions. Consistent data on epidemiological data on showing those associations with exercise and survival. And again, definitive phase 3 clinical trials are on the way to respond to some of these questions. And mechanisms related to exercise in terms of tolerance and efficacy. All this work is sort of underway, trying to understand what are the potential mechanisms around exercise and potentially improving survival. And myokines are certainly an important target here. We also spoke about some of the updated guidelines for exercise in prostate cancer. They are ready to use, and patients can actually benefit quite substantially by doing this work now. The evidence is there and should be used now. I'm just going to point out what an AEP is, an accredited exercise physiologist. These are different than the personal trainer that you see at the gyms. These people, they went to a university, they have a 4-year university degree with clinical training. Some of them have cancer-specific clinical training, and you can search from that on the WESA website if you are thinking about finding someone to work with you and to prescribe you an exercise program. This is within Medicare. So there are sessions that can be rebatable through Medicare, through the Enhanced Primary Care Program, and also private health insurance as well can actually cover some of the costs associated with our AEP. So our AEP can be found in your regional areas or local metropolitan areas. This is through the ESSA website. You can find an AEP there. Again, not all of them will have training in cancer, but some will, and you can actually search for their specific expertise. I'd like to acknowledge the research team here at Emory, working for a number of years, the academic staff, professional staff, the postgraduate students did an outstanding work in their part of their research program, and also the patients that have been working with us for a number of years, and hundreds and thousands of patients going through our programs and our clinical studies. and also support from a number of funding organizations, including PCFA, has been absolutely essential for the work done here at ECU. We do have a number of research studies open for recruitment, and for those that are interested and are living in Western Australia, I know we're talking to all of you, in many areas, in many states, but those in Western Australia, there are existing trials. If you have an interest, you can be in touch through the Emory website, the Exercise Medicine Research Institute website. This is the site and this is the email. So we're very happy to communicate with you and answer any questions and try to facilitate any referrals to exercise program. Thank you, Chris. Thank you, everyone. I'm very happy to take questions.
I'll just get you to stop sharing your screen there, Daniel, and then we'll... Perfect. Great. So thank you very much for today. That was really good. Let's a lot of information to cover in such a short amount of time. A lot of really good information to cover in a short amount of time. So a few people have got some questions that have been submitted through. So we might just go through those. And if you've got any questions, please put them through the Q&A session box at the bottom of your screen, and we'll endeavour to answer those. So we've got about sort of 10 to 15 minutes for a couple of questions now, Daniel, if that's okay, and we'll get rolling with those. So one of the first questions is, so for those that have had undetected cancer following surgery, what might be the ongoing benefits of having an exercise physiology program? And are there any specific benefits that affect the pelvic floor, for instance?
I think it's an important question, and this might happen. Surgery might happen, and patients might have the disease coming back later. Again, undetected cancer. Often, some of these patients, they will undergo androgen deprivation therapy, for example, or radiation. So exercise first will be very important to offset some of these toxicities and side effects that we spoke about it. Patients tend to lose their muscle, to gain fats, to have cardiovascular metabolic issues, even the mental health aspect. So exercise per se will be quite important in that setting. Yes, for undetected cancers following surgery. So it is a long-term sort of thing, and ideally to be done weekly on a regular basis. And again, the data accumulating of being more physically active and you have a greater survival benefit that is associated with exercise. So I think there's a lot of benefits associated with exercise in that particular stage.
So I guess the next question we've got comes through at a different stage. So someone who's had, I guess, a few treatment modalities and have had a few, I'm just reading the question through, has a few attachments because of their side effects or the degree of treatment of their disease. They've got catheter bags, perhaps some bowel bags, drips, etc. But at home or in the community. Is there some form of exercise that's easy to do for someone who's not as, I guess, mobile because of some of those physical aspects that they have with the current arrangements they've got?
So Chris, this is again an important question, and it comes back to the ESSA guidelines. I mean, it's very individualized, and patients who have greater needs in specific areas, certainly exercise can still be done. It's still safe. I think it needs to be assessed and prescribed by an exercise physiologist. I mean, this can even be done via telehealth. So at least getting them started in the program, even though there are some sort of barriers and difficulties in being mobile, it can still be done.
So you just hit the nail on the head there. That ESSA website is fantastic. I used it a lot in referring people to accredited EPs. So it's a really important website to find out who your local EP professionals are around your area. But a question here's come through that this all sounds really great. But what about some of those that are in more rural, remote areas of Australia that don't quite have access to these particular services? Is there perhaps some programs they can follow online or go through their primary health within their areas at all?
Yeah, again, good point, Chris, and this is a great question. I mean, I guess with COVID-19, we're trying to understand and learn how can we deliver these programs to other areas and people that can't leave their houses or are in remote areas. Yeah, so exercise physiology, I mean, this type of programs, they can be delivered via telehealth, and it's being done. It's certainly being done. Perhaps the advice would be to search, maybe the general practitioner who knows someone that can, in their specific areas, are actually working in that space of telehealth and facilitate. I mean, we are doing this work here. In fact, we're doing trials, trying to understand if face-to-face has the same sort of efficacy as telehealth. So this work is being done as part of clinical practice and also as part of research. Yeah, more needs to be done though. More needs to be done in terms of how can we reach these patients that are in areas that are not as accessible.
So I guess that kind of leads into a little bit of perhaps communication with the medical fraternity from a allied health point of view. A couple of questions, I'm just going to roll them into one, but they've kind of looking at what kind of communication. The guidelines are fantastic, but how do we get those guidelines in front of urologists and rad-oncs that are in this space so that then they're giving their patients an opportunity to engage with exercise surrounding their treatment? So how do you think that it's being facilitated right now, and is there a way that we can improve that communication for getting exercise guidelines utilized by others within that clinical network, the urologists, the radiation oncologists, and so on?
Yeah, this is good, Chris. I mean, it's an important point. I think since we started in this field, exercise was actually contraindicated. Now it's actually part of the discussion. It's not mainstream therapy, but it's an important medicine that should be, prescribed alongside, the major treatments. And again, has been endorsed by 17 international organizations as a medicine in oncology. I mean, we try to be in meetings, national, international meetings with physicians, urologists, and medical oncologists. I think this is now starting to be part of the discussion. Certainly more work it's required, but it is part of the discussion. Yeah, and again, the person that will actually prescribe that referral will be the GP. So the general practitioner might have a potentially a more clear link with an allied health professional. But I think the patient can certainly discuss with the urologist, I'm interested in exercise, and what are the opportunities? Yeah, I would think that this is kind of changing and improving. More work needs to be done. But yes, we're progressing in this area. Some of the clinicians are actually very enthusiastic, and they refer every single patient to an exercise program. But this gap, between science and what we already know and what's being done, it's still there. There's a gap there that I guess PCFA is doing brilliant work in survivorship, and we're trying to fill up that gap. How can we connect patients and nurses with, exercise specialists and urologists? That work needs to be enhanced. Yeah, but there are pathways there, and we're better than what we were years ago.
Yeah, good answer. So I guess while we're just discussing GPs, one of those things that often comes up in our webinars is about how do people know what to say to their GP in order to access services. So some of the kind of conversations that I see within our online community, definitely about that access to everything from exercise, physio, all those allied health services through the GP management plan. So would you recommend that people go and have a chat to their GP about a management plan in regards to exercise if they have a diagnosis of prostate cancer?
Oh, absolutely, absolutely. That's the best pathway. And it's a pretty unique pathway. It doesn't exist elsewhere. I think there's one or two places in Europe, in Germany, you might have some sort of access. North America, nothing. Australia is really ahead of time. I know it's only 5 sessions, and it might be mixed within allied health profession, but that initial consultation is actually quite important. And yes, people should use that. And if you do have a private health insurance, for those that do, there's more additional coverage in relation to exercise physiology. That's certainly the way to go.
And that comes there. Somebody else has asked a question about the cost associated to some of these exercise groups and EP visits and things. So generally, you can go along to your GP and have the initial visits with allied health so that you can get on track with where you need to kind of direct yourself, I guess, in regards to some of that exercise. So have those open conversations with your GP and ask about the management plan options. I know that if it is a benefit to you in your diagnosis, that you can extend some of those 5 visits within a calendar year as well. So definitely have that conversation with your GP. Somebody else has asked, I guess this is a good question, or also case study, is that how many younger men do you see within these exercise studies? If we're talking a little bit more about perhaps more advanced cancer, how many, is there a proportion of, are you seeing more younger men now coming through with perhaps advanced metastatic disease that might be a little bit more fit and active than what
not necessarily. I think the average is the 65 plus, which is the sort of average for prostate cancer, 65, 68. That's the sort of average. Yes, occasionally one younger, some older, but that's the sort of average that we see. Yeah, as part of all these studies that we presented.
Yeah, perfect.
But I think irrespectively, exercise can help all these patients, right? Yeah, irrespective of age, that would be a beneficial effect.
I guess in West Australia, you've got some really great sort of prostate cancer exercise groups that are happening over there. Could you speak to kind of the benefit, I guess, of that peer experience within a exercise group program?
Absolutely. This is interesting. We just actually wrote a piece. I'm lucky to write with a great colleague, Suzanne Chambers, a psycho-oncologist, and we're sort of reviewing the area. It seems that one of the facilitators for men with prostate cancer is to adhere to long-term programs, is to be in a group. It seems to be a positive experience. We see here in our programs, people tend to stick and adhere long-term. Even when they finish the research studies, if it's 12 weeks, 6 months, they tend to stick together and work as a group. Certainly there are individual preferences, and some people, they want to do it individually, but it is certainly an interesting aspect. It's almost like a support peer group working together and talking about issues and exercising at the same time. So in our experience, and I guess Google literature is also suggesting that it is an interesting facilitator to uptake and adhere to exercise long term.
I guess that brings us to the last question, talking about adherence to these programs. So as we were just saying before, if somebody's really motivated and obviously gets along and gets a few visits, subsidized on through their GP management plan, and they're actually getting moving, once that stops and sometimes other barriers pop up, is there a retention rate, I guess, for people continuing to exercise? Have you seen any ebbs and flows, I guess, within the research to suggest that, some people perhaps go hell for leather for a period of time and then reduce what they're actually doing because
it's
of
interesting. Yeah, and again, one of the major barriers of exercise, and this is within the prostate cancer literature, is side effects and symptoms. So I guess we're showing here, and it's well known that the more symptoms you have, the more benefits, and the more you respond to an exercise. So there has to be some sort of conversation with patients that, hey, you have more fatigue, you're the one that should be exercised because you're going to get the greater benefits. So that's one aspect. The other aspects, the other one is time. Even though, okay, some will be retired and so on, but time is an issue. And again, not just in prostate, but in other groups, it is a major barrier. The data in terms of adherence, it's actually pretty strong. We see 70%, 80% adherence following 12 weeks, 6 months exercise training. And patients, they tend to get the benefits, and they tend to use that as a lifelong behavior change. So dropouts are normally happening early, not later. And early are probably for those that have more symptoms, which are the ones that should have the most benefit. So there has to be some sort of discussion and to bring these people into these type of programs.
Yeah, I guess Miranda's just put a quick little question into the chat function here about the public versus private sector when it comes to having EPs readily available. Are there any sort of exercise physiologists within public health in Australia that you're aware of?
So that will be within the Medicare. Yes, those 5 sessions, anyone who have access. I mean, the private, I think we've mentioned privileges. For those that do have, they might have additional sessions. But as a public patient, you have at least 5 sessions in a calendar year with a referral from a general practitioner, which is outstanding from an international standard, because it doesn't exist anywhere else.
Yeah, no, it's a great program, and you can access it for a number of the side effects with prostate cancer as well. So it's have those conversations with your GP. You can get single visits to a EP, or you can also have those group sessions after you've been assessed for appropriate exercising as well. So it's really important to have those conversations with the GP, see what you are available to access as well. Really important. So we might wrap it up there. A couple of other questions we can answer directly as well. But I'd like to thank everybody actually for joining us today, and especially you, Daniel, for your time. I know you're a very busy man, and you know, making some really big change in this space for men over the last few years. And I do thank you for your time, your insights, and your expertise today for our PCFA Educational Webinar. If you'd like to watch this webinar again, or would like to share it within your networks, head over to the PCFA online community or the PCFA YouTube channel to watch a recording of the webinar, which should be up within the next 24 hours. So keep up to date with any PCFA activity or updates by signing up to our newsletter on our website as well. Until next time, stay safe, and thank you for tuning in.